We'll start in a few minutes, sorry. So please, the presentation is being streamed online on YouTube. So any of your colleagues who cannot enter the room, they can watch and see and interact with the presentation on YouTube. So you just need to write my name, find my channel, and you find the streaming, the first video. So today our talk is about care of sick child. We did one session before, and we reached to, we're still in the primary assessment. And if you guys remember, we said resuscitation first, find the person conscious or not conscious. If unconscious, then is breathing or not. And after that, you shout for help, activate the alarm, and then activate the alarm or whatever emergency code you have in your institute, and then do your assessment, which is the primary assessment, secondary assessment, and the diagnostic test. And we said the primary assessment is based on the A, B, C, D, E, and the secondary assessment based on the acronym SAMBLE, and then the diagnostic test. So we finished the A, and we started B, which is the breathing. And in the breathing, we finished the heart rate and the breathing effort. Okay, so if you guys have any question about the previous session, please ask me now. And if somebody, one of you time me, so I'd stop after 1 hour because sometimes I forget, and then we can finish the next session. So please just remind me at 1 hour from now to stop talking, because I can keep talking for 2 days. So please remind me to stop talking if you are bored with the presentation. Okay, so let's start. Okay, so this is the last slide we took about the primary assessment, about the breathing, and we talk about how to assess the breathing effort and what is the causes of the breathing effort and how to differentiate between upper and lower breathing effort, and what are the diseases that causes the upper and or lower respiratory problem. So I'm not going to repeat it because we've talked about it. And of course, any healthcare provider who work with newborn babies, they have to know what are the meaning of some words, because some of these words are being used by healthcare professionals and they are actually jargon for them. They think they know. So for example, you ask a woman or a mom, what, she said the baby has a diarrhea, but when you ask her, what is diarrhea? She's totally confused. Sometimes she means frequent bowel motion. So when we say grunting or wheezing or stridor or upper airway or lower airway, one should know what that means. So we finished with the breathing part. We finished with the breathing effort and respiratory rate. Now we're going to third part of breathing assessment, which is the chest expansion. So normally the human being, and especially newborn babies and children, can take somewhere between 5 to 7 ml of tidal volume, and the tidal volume is the amount of air or the volume of air that we breathe in. The second point is that whether the breathing or the chest expansion is symmetrical or not. When we do that, we should completely uncover the baby from the chin to the diaphragm, and it's better to be up to the umbilicus. Because sometimes you don't see the movement, especially newborn babies, and sometimes people think that the baby is not breathing, but most of babies they breathe by abdomen. And therefore, it is important when you assess a newborn babies is to assess the heart rate as an indicator of, can you mute yourself, please? As an indicator of there is breathing. So remember to uncover the abdomen if you don't see a chest rise. Now, remember the assessment or the primary assessment and secondary, and then composed of assess, identify, and then intervene. So when we assess the chest expansion, our assessment, we have to say inadequate effort, airway obstruction, atelectasis, there is a disease problem such as pneumothorax or hemothorax, or there is fluid such as pleural effusion, or there is obstruction of airway such as by blogging, or there is foreign body. When we assess the breathing, we have to do first to see a chest movement. And if we don't see a chest movement, we have to look to the abdominal movement. If we see a movement, that does not mean that there is a breathing process, because breathing process is effective ventilation, which means taking out oxygen and providing oxygen. So after you see the chest rising or abdominal movement, you have to listen for air entry, and the best is to do it in both axillae. So after we've seen the chest expansion and we decided whether it's inadequate or obstructed or what is possible reason, we listen to the sound. So we can listen the stridor, or it's the inspiratory noise, and it can be many. It can be by foreign body or by infection or allergy or congenital problem or following a medical procedure. We have to decide a grunting, and we've talked what is a grunting, and this means that there is alveolar or small airway problem. And there are many ways: pneumonia, RDS, burn, heart failure, bowel obstruction, all can cause grunting. You can see gargling movement, which is usually present during inspiration and expiration. And it can be because of the fluid, whether fluid from the respiratory system or from the GIT. We can see wheezing, which is the noisy expiration. And it's a musical sound, and it can be any reason for lower airway obstruction. You can have also crackles or rails, which is a noisy breath. It can be inspiratory or expiratory, and it's less than gargling. And gargling, you can hear it by your ear or without a stethoscope. And while the crackles and rails, usually you need a stethoscope, and the crackles and rail, usually you hear it for fluid in the lower airway, such as presence of pneumonia or pulmonary edema, and interstitial lung disease. And you guys have to know what is interstitial lung disease. You have to know that with the chest expansion, to achieve the tidal volume is not the only point, but we need something called minute ventilation. And minute ventilation is a tidal volume over 1 minute, or it's the tidal volume time the respiratory rate. So which means that your tidal volume can decrease if you have a small tidal volume, and it can increase also when you have a low respiratory rate or a very high respiratory rate. So when the respiratory rate more than 60, especially for pain, you won't achieve tidal volume. And that's why it's very important when you have fast breathing to calm down the patient or give sedation if you are on respiratory support. And therefore, in adult, you're more dependent on tidal volume, but the younger you go, you're more dependent on the respiratory rate. The other assessment, in addition to the respiratory rate, to the breathing effort, chest expansion, listening, you also need to check the saturation. Now, of course, we have two types of saturation. Here, I only talk about pulse oximetry, but you also can measure the local tissue oxygenation by NIRS, near infrared spectroscopy. So, and I'm going to tell you a little bit about both. So, pulse oximetry is measurement of the amount of the hemoglobin attached to the oxygen, or what we call it oxyhemoglobin, from a percentage of total hemoglobin. So the total hemoglobin can be carboxyhemoglobin, can be methymoglobin, can be M hemoglobin, can be silver hemoglobin, whatever the hemoglobin is. So, and therefore the pulse oximetry will not see, for example, methemoglobinemia. So it measures the percentage, and therefore you will never have you will never know what exactly the number, but you can get the percentages. So the extreme hyper and hypoxia will not be assessed. And again, like any scale, the more you go to the extreme, the less accurate the assessment. And for example, the normal values for saturation is more than 94. And the reason for more than 94, because 94, 95, 96, and up to 100, it's the same number. Because the more extreme you go, the less accurate. And even when you have 30 or 40 or 50 or 60 or 30, it's the same. There is no difference, because the more extreme you go, the less accurate. The other point, because it measures the oxyhemoglobin, it affected by the perfusion, and also it affected by the hemoglobin, such as anemia, because it measures not only oxygen, it measures oxyhemoglobin, and it also affects if there is irregular pulse. And it measures the oxygen in the artery. It measures the whole oxygen, but it's more arterially weighted. So in pulse oximetry, you measure about 75% of arterial, and the rest is for the body. The normal is more than 94 for infants and children, and it's 90 to 94 for premature babies. The near infrared spectroscopy, it measures also the pulse oximeter, the percentage of oxygen saturation, and sorry, I have to admit people. And it measures more venously weighted. So it measured by NIRS, it measured about 75% venous and 25% the rest. And therefore, it measured the local tissue oxygenation. Therefore, they call it RSO2, or regional oxygen saturation. Dr. Deepak, if you can kindly mute yourself. And because it measures more venously and the pulse oximetry measure more arterially, then the difference between them is arterially is the oxygen consumption. Not only that, because it measures the regional oxygenation, we can measure the brain oxygenation and we can measure the somatic. And as you know that most of the somatic are they can deprive themselves to provide the oxygenation to the brain, and the brain is persistently taking oxygen. And because it's persistently taking oxygen, the venous oxygen is low, and therefore the regional oxygenation of the brain measured by NIRS is always low, below the somatic, because somatic takes slack. The other point, the somatic is going up and down because of autoregulation to keep constant flow for the brain. And therefore, these are very good two measurements to measure the autoregulation and the difference between somatic and cerebral. And also, you can find the difference between pulse oximetry, arterial, and NIRS regional to find the oxygen consumption rate. And when you find oxygen consumption rate, you can calculate the cardiac output. Any question? If anybody has a question, especially if I'm saying some difficult stuff. Any question? Okay, so we finish with the primary assessment, the A and B. The A was airway and B was the breathing. Now we will go to C. And in C, we assess the circulation. So in circulation, Dr. Nasser Najm, what do you mean الحصول على المحاضرة? What do you mean by getting the lecture? What does that mean? I don't understand. Anyhow, so for circulation, we check the heart rate and the rhythm. We check the pulse, peripheral and central. We check the capillary refill time. We look at the skin color, and also we assess the temperature of the skin. We check the blood pressure, urine output, and the level of consciousness. Because level of consciousness, if can be presented with a neurological manifestation. I mean, the circulatory failure can be present with a neurological manifestation. So let's start with the heart rate and the rhythm. So in newborns, you know that there is very high rates ranging between 120 to 160. It can reach sometime up to 180 when the baby cries, and it can reach down to 100 when the baby is quiet. When you get older, in the first 2 years, you get about less by 10 to 20 event per minute. And after that, you get about 50% less. And more than 10 years, usually you are somewhere around 75 event per minute. You can get ready in athletes. For example, I do lots of exercise and my heart rate is 30. So in athletes, you get very low heart rate. Also, you have hypoxia, you get very low heart rate. And you can get tachycardia, sinus for fever, for pain, for distress. And there are many other conditions unrelated, such as hyperthyroidism, such as, as I said, fever, such medication can cause you high heart rate. And then after you measure the, assess the heart rate and the rhythm, you measure the, of course, we are not speaking here about the arrhythmia, but we will speak about arrhythmia later on, because now we are assessing only the circulation. So the pulse, we can check central, femoral, and brachial, carotid, axillary, peripheral, it's a radial, dorsalis piece, or posterior tibial. And when we measure, there is a difference. We have to consider the peripheral vasoconstriction. And when we assess the pulse rate, we assess it from normal to weak to arrest. And we have to see the peak-to-peak variability. As you know, human being never fixed or never stationary, never plateau, always change. So no, sir, you cannot get the slide, of course. You can get the PDF. These slides are private. I cannot provide you the slide, of course. I can provide you with PDF format of the study, but I cannot provide you the slides. And also you have a video presentation of the lecture. When there is peak-to-peak variability, that's when you are alive. When the heart rate or the pulses are plateau, that's when there is a problem. We also, we can see premature atrial contraction and premature ventricular contraction. We can see pulsus paradoxus in asthma and also in pericardial effusion, and we will speak about pulsus paradoxus later. So we assess the heart rate, we assess the rhythm, we check the pulses, and now we check. Now, when we check the pulses, it should be only one side. So especially when you check the carotid, you don't check both sides. But if you check peripheral, you can check both sides to see the difference between right and left. And you can also check the difference between upper and lower to assess for certain congenital heart disease. You have to check capillary refill time, and you only need to say is less than 2 seconds or more than 2 seconds. So what you can do is you elevate the limb above the heart, above the level of the heart in a room temperature, and then assess the capillary refill time. So from these, you have to think about the cardiac output. It usually decreases in shock. and it leads to low systemic perfusion. Usually the drop in the perfusion starts central and then peripheral, start peripheral and then central. Remember, when the extremities are cold, there is probably vasoconstriction. Also remember, when you talk about capillary time, you say, is it delayed or sluggish or prolonged or it's a normal? Yes, Dr. Deepak, told me. Tell me, sir.
One query, sir. Actually, how to diagnose in a labor room to the newborn that this is a cyanotic? What is the symptoms of cyanotic heart disease of a newborn, sir?
Oh, sir, sir, Dr. Deepak, the presentation is about care of sick baby, not diagnoses the congenital heart disease. So a cyanotic, but I will answer your question. A cyanotic congenital disease are two types, volume overload and pressure overload. The volume overload, when you have right, you have left to right,
yes,
shunt through ASD, VSD, PDA, pulmonary window, arteriovenous malformation. So you get volume overload. And other disease, you have a pressure overload. So you have aortic stenosis, pulmonary stenosis. You have hypoplastic left or right side. So that's a pressure overload. Both are acyanotic. While the cyanotic, when you have right to left, so you mix the less oxygenated to the oxygenated. So the right to left, you have also to know what is right to left when you have the pressure on the right side more than the left side, such as TOF, such as persistent pulmonary hypertension. Now, how to diagnose congenital heart disease? There are many ways: antenatal scan, clinical assessment, and screening for critical congenital heart disease, and also doing point of care heart scan or doing actual echo by a cardiologist. But the presentation here is not
okay,
about.
I'm sorry, sir. I'm sorry.
That's okay. That's okay. I understand. Okay. So, so circulation. When we assess the circulation, now we did the assessment. Now, I mean, we assess. Now we have to identify. So from skin color and temperature, we have to say, is it pale, or it's mottled, or cyanosed, or there is hyperthermia or hypothermia. So pallor means there is less blood going in the peripheries. It can be due to cold, it can be due to stress, it can be due to shock. It can be due to anemia, or it can be due to skin pigmentation, such as having dark skin due to sun exposure. And then also the pallor, we have to say, is it central or peripheral? Mottling is usually a vascular problem. So mottling is either nothing, vasomotor instability, or a grave sign. So you have to be careful when you see mottling. Cyanosis, it's a peripheral or central. And as you remember, cyanosis, when we have the carboxyhemoglobin more than 5 grams. And if you remember, when we say pulse oximetry, measure oxyhemoglobin from total. So whether the rest is carboxyhemoglobin or methemoglobin, the pulse oximetry will not know. So the 5 gram, around 25 to 30% of the whole hemoglobin, and therefore we will not see the cyanosis until the saturation drop down to by 30 to 25 to 30, which means 70 to 75. Central can be many reasons: congenital heart disease, adult respiratory distress, asthma, pneumonia, overdose, trauma, and also high altitude. Temperature, it can be hypothermia, depending on the situation. It can be by infection causing hyperthermia. It can be stroke, heat stroke, or it can be environmental, and it can be cold, and the cold also have various reasons. Also, when we assess the circulation from skin color, we have to assess the blood pressure. Now, this blood pressure issues are being, escalated and being changed. Before we use numbers, and then we start to use centiles. And then now I think even centile is not enough. We have to use the trend. Also, you have to know the way you measure what is the way you are using to measure the blood pressure, and what is the drawback or the weakness of the measurement. The second is the age, the height, and the gender. All this can affect your reading, and also how proper you're measuring. For example, you have to have the cuff or the ladder of the cuff to cover about 40% of the mid-arm circumference. If less, then you get high pressure. If more, you get low pressure. And also it have to encircle about 75%. It's good to be more than 50, but it's best to get 75% of the length of the arm or the thigh. Most of the hypotension in acutely sick baby is due to loss of fluid, especially bleeding. Remember, if you have a bradycardia and hypotension, it's a very ominous sign. This is a very short and gross numbers just to give you an idea, but you should not use it. You have to use the centile based on the age and the gender. And with that, even is not enough, you have to consider the height or the length of the baby. And that's also not enough. You have to look for the trend. So what you can do, whether you're using invasive blood pressure monitor or non-invasive, you get few numbers. For example, you measure it every 15 minutes over 2 hours, and then you get trend. You have to use the systole and diastole, and also use the pulse pressure. In addition, use the variability, the up and down between events. And that's very important, considering healthy blood pressure is the presence of variability. And there are other tools to measure the variability. Now, there is no time to talk about. These are another very broad, even broader than this to use when in a very acute situation, these numbers. So, the systole less than 60 in 1 month old, and more than 60, less than 70 in first year, and less than 70 plus the age in year times 2, and less than 90 in 10 years old. For this is the diastole, yeah. Remember that there are very important signs for circulation is the urine output. So for newborn babies, it's better to have it more than 1.5 ml per kg per hour, while for the pediatric, it's okay to have more than 1 ml per kg per hour. So we finish with A, B, C. Now we move to D. And D is what we call it disability. What is the consequences of being sick on your systems? So we have neurological signs of circulatory failure, such as the level of consciousness. And when we say circulatory failure, we mean that less oxygenation or less oxygen going to the brain. And these are change in consciousness, muscle tone, pupil response, and presence or absence of seizure. There are subtle signs of neurological deterioration, such as confusion, irritability, lethargy, agitation alternate with lethargy. And then we need to know what is confusion, what is irritability, and what is agitation. We have to use the acronym of POO, which means alert, verbal response, pain response, and unresponse. This is very quick assessment for neurological status. Or we can use the Glasgow Coma Scale. And we divide it to mild, moderate, and severe impairment. And these numbers come from 4 points for the eye, 5 points for the verbal response, 6 points for the motor response, and they are total of 15. So if they are more than 12, they're usually normal. If between 9 and 12, it's a mild impairment. And 9 to 12, it's a moderate, and 15 is normal. 13 to 15 is a mild involvement, and less than 9 is a severe involvement. We can also use the acronym PURAL to assess the pupil, which means pupils are equally reactive to light. So these are how you assess the disability. Remember, it's a primary assessment. We talk about airway, breathing, circulation, and now the D. So decreased consciousness can be caused by many things, such as poor cerebral perfusion, trauma, encephalitis, meningitis, or both, meningoencephalitis, hypoglycemia, drug hypoxemia, and hypercarbia. Once you have change in consciousness, the first thing you assess is the oxygenation and ventilation, then the perfusion. After the D, we go to the exposure. So the exposure is to completely undress the patient, assess the face, front and back, assess extremity and skin, maintain C-spine for trauma, very comfortable neutral position, use a blanket to cover and uncover the patient, and look for evidence of trauma, bleed, burn, fracture, bruises, non-accidental trauma, petechiae, and purpura. Okay, remember that the primary assessment are composed of A, B, C, D, E. And remember, when A, we said identify, intervene. And in airway, we say, is it maintained or unmaintainable? Unmaintainable is complete or severe obstruction. Breathing, there is apnea or increased work of breathing. Circulation, you have to say poor perfusion, absence pulses, hypotension, brady. Disability, is there is any signs or not, and then exposure. So in disability, the most important is responsive or unresponsive, and if it's responsive, whether there is decrease in level of consciousness. And exposure, is there a significant hypothermia or bleeding, or we are in change in temperature. Now, we said, remember, evaluate, intervene, identify, and the evaluation after you shout for help is a primary assessment, secondary assessment, diagnostic test. When we interfere after the primary assessment, we interfere only when there is life-threatening condition and we are not certain what is wrong. And by this, we finish the primary assessment. Okay, any question for the primary assessment? Questions? Any question? Should I move to the secondary assessment? Questions? No? Am I too fast? Should I slow down? No answer? Or talk to me, you don't need to text me.
Your face is very good.
Okay, great.
It's excellent.
Great, so let's go.
Excuse me, doctor. Excuse me.
Yes, go ahead, please.
Doctor, regarding the Glasgow Coma Scale, it is different a little bit now. There is something called the modified Glasgow Coma Scale. Is there any big difference between both or not? Please, if you can explain these points.
We will talk about the Glasgow Coma Scale in next few slides, about how to do it exactly. Most of the time, you don't need even Glasgow Coma Scale because you don't have time. So you go with acronym AFBU. But whether it's modified or not, you modify it for certain diseases and you modify it for gestational age and whether the patient are communicable or not, or there is language barrier. These are the modification of Glasgow Coma Scale. But the purpose and the ultimate is the same, like the ultimate result.
Okay, thank you very much.
Okay, for the secondary assessment, we have focus history and focus exam. In the focus history, we use the acronym SAMPLE. And remember, our evaluation is primary assessment, secondary assessment, diagnostic test. So S for sign and symptom, A for allergy, because remember, you are chasing time. You are want to catch up. So that's why focus history is very important in doing the secondary assessment. After you did the primary assessment, you identify if there is a left threatening condition, you treat that threatening condition, or also you treat the ABCE when you don't know what is going on. You know that there is something wrong, but you're not sure what is it. So after you done that, you go to the secondary assessment, and it's composed of two parts: the focus history and focus exam. The focus history includes sample, so sign and symptom, allergy, medication, past medical history, last meal, and event. Now the last meal is important for intubation. And then you do focus exam. You concentrate on the area of interest, and then you do head to toe. After you do the focus history and focus exam, you are some diagnostic tests. The most important is do ABG. Okay, and sometimes you can do CBG, but when you do CBG or capillary blood gas, you only use it for CO2 and pH and bicarb. You do not use it for oxygenation. Only oxygenation in the ABG. The VBG is actually useless test. It's important for pH in diabetic ketoacidosis and also in poisoning. But other than pH and maybe bicarb, it's not, it'll give you all the readings are not necessary, and you cannot depend on it. I think Dr. Miradia Husseini, can you mute yourself, please?
No, I'm sorry.
That's okay. You don't need to be sorry. Just mute yourself. And if I know if I spelled your name or pronounce your name correctly, I'm trying my best. You can do also central venous oxygen saturation, and you can ask for arterial lactate level, very important. You can also do the venous pressure monitor, and many people think that it should be, you can use it peripheral, but you can use central if you have central line. And if you don't have central monitor, you can use your infusion pump or infusion syringe to give you a broad idea about the venous pressure. You can use arterial pressure monitor, whether it's umbilical or it's a radial or it's a posterior tibial. You might ask for chest X-ray or point of care ultrasound, ECG, echo, and also you might do pulmonary function test. Remember that when you do venous and you want to check the PCO2, there is difference between arterial PCO2 and venous PCO2. We depend on the arterial. And the difference is up to 10 millimeter mercury. And of course, the venous will increase when you use tourniquet. Normal oxygen saturation, systemic arterial oxygenation is should be more than 75%. When it dropped to 70 to 75, you get cyanosis. The normal level is in child is more than 94, and in a premature baby it's 90 to 94. Now, after you've done your primary assessment, secondary assessment, and then diagnostic test, you need to play as a team. So rule assignment is very important. You have to assess, or you have to assign who's the team leader. And the team leader is not necessary to be the most expert. Usually it's the most expert, but it's not necessary. And it's not necessary to be a doctor. The team leader, it does not mean necessarily that he knows better. It's just an event organizer. So he asks member A to do this, member B to do this, and then member A do something. And if he or she did that thing, they should reply what is the result or there is difficulty. The team leader should be about 2 meters away from the patient. And we should be trained on the dynamic and effectiveness of resuscitation. The resuscitation should be, the communication should be loud and clear, and there should be a role assignment. And I wish I do lots of resuscitation in the labor room, and I wish I videotape one of them, but was like most of these scenarios are emergency and I don't have time to record them. But also very important in the team dynamic is the parent and family members. Now, in my practice, I bring the patient or the family member with me, and I assign one nurse or one team member to speak with them, to tell them what exactly we're doing, and we have nothing to hide. And I found this, I have almost zero complaint. So remember, role assignment, team member, position of team member, assign who's doing what, and the person who knows how to do it should do. So one do the breathing, one do the circulation, one do, for example, the IV, other one, document, the other one bring the medications, the other one, make phone calls for help and support. So you have to have a dynamic, and it's necessary to involve the family members, otherwise you'll have a complaint. The communication should be closed loop, which means when I give an order, I should receive a reply. The reply can be negative or it can be positive. So check the heart rate. I check the heart rate is 100. I check the heart rate, I couldn't assess it. Do ventilate. I am ventilating, I'm not getting chest rise. I'm getting chest rise, but there is no air entry or something like that. So the message should be clear. Order from the team leader. The recipient should say, I am assessing the heart. I am doing the line. Or I have difficulty and we have no something. So the role assignment should be clear, and everybody should be accountable for responsibility. If he or she has a problem, she needs to ask. She or he can need for help. Each person, and especially the team leader, should know the limitation of team members. And we should share the knowledge. So let's say I said to member A, please give adrenaline 0.1 milligram. Some of the other members think that I'm wrong. No, sir, there is something, the dose is incorrect. So please, member B, check the dose. Therefore, that's what we call it constructive interventions. Always reevaluate, because remember, we are a cycle of 30 seconds, which is assess, identify, intervene, and then reassess. Always summarize. So we are 1 minute of resuscitation. We're establishing the breathing. We're establishing the circulation. Somebody's doing core line, somebody, something like that. And remember, respect and proper tone. It should be clear, very clear and obvious, but should not be rude. But sometimes during stress, you might be rude and people might take it. How you know you're rude? You have to ask other members whether they take your communication as being rude or not. Sure, you can get the PDF. Somebody is asking me for the PDF format of the presentation. Yes, sure, I can give the PDF. So now we already talked about the general frame of the resuscitation. Now we will talk about the problems, how we recognize problems. So let's start with recognition of respiratory problem. Hypoxemia means arterial oxygen content is being low, and the arterial oxygen content depends on the oxygen and the hemoglobin. So it's 1.36 times the hemoglobin concentration times the saturation, and plus the 0.003 times the partial arterial pressure in the artery. So, and then if we don't have some numbers, we can look for indirect signs of hypoxia, such as tachycardia, tachypnea, or respiratory distress in form of nasal praying or retraction, agitation, because remember, when the baby or the patient is hypoxic, he becomes agitated, and he or she will not be responsible on his or her action. So, for example, they might take off the oxygen supply or the cannula. In that situation, you need to sedate. Pallor is also a sign of hypoxia. Cyanosis is a very late sign. As you know, saturation should drop by 25 or 30%, and decrease level of consciousness by a VU or by Glasgow Coma Scale. Bradypnea or apnea, also a late sign of impaired oxygenation. Also, we can have impaired ventilation. That means we don't have a proper CO2 exchange. So inadequate ventilation, and you remember it's a minute ventilation, is a tidal volume plus respiratory rate. It's very difficult to detect and produce no symptom. Remember, the low CO2 is way dangerous than high CO2. And high CO2 to cause a problem, it takes long time. And remember, we breathe by CO2. We don't breathe by oxygen, which means if we have hypoxia, we will not have apnea. But if we have good oxygenation, we will not have apnea. But if we have high CO2, we will not have apnea. We'll have apnea only when there is low CO2, because we don't need to breathe. The body understands we don't need to breathe because we are washing CO2. The CO2 can be measured in the artery, in the vein, in the capillary, and also in the exhale. In the exhale, there are many ways. There are the calorimetric, so it changed to blue, yellow, blue. It changed to green, yellow. Or you can use the capnography. The capnography are many types. It can be continuous capnography, and there are two types: mainstream capnography and side stream capnography. And there are also the end-tidal CO2. We can also measure the skin by measuring the transcutaneous CO2, and we can measure in the blood gas. We also can have some indirect signs of inadequate ventilation, such as tachypnea, nasal fraining, agitation and anxiety, and decreased level of consciousness. So, what are the factors that can affect our assessment of respiratory problem? First, low oxygen in the environment, such as high altitude. Why we have, what will happen, it gives us low oxygen. What we need to supplement oxygen. And I hate the word supplement oxygen. When we say supplement oxygen, it's an emergency. You cannot give oxygen to the patient. We have to give a blended, heated, humidified oxygen. Blended mean oxygen and medical air. And medical air mean a compressed air, like in a fridge or in a pump, but filtered from particles and bugs. So we should always give supplemented blended oxygen. Alveolar hypoventilation, it can be due to CNS infection causing apnea, traumatic brain injury causing hypopnea or apnea, drug overdose, neuromuscular disease, or central apnea. Apnea mean no ventilation, mean accumulation of CO2, mean high PCO2. High PCO2 will displace the oxygen because you'll have more CO2 in the alveoli. Decreased oxygen tension cause hypoxemia. So the effect of hypercarbia is very late. And most of the time, if your saturation is okay, you can give what we call permission hypercarbia. If you're desaturating with hypercapnia, then you need to correct. But most of the time, I wait until 60 and 70 if I have a normal CO2. So you need to restore ventilation, and remember, it's a heart rate, it's a respiratory rate and tidal volume, and you need to supply oxygen. Also, you can have a problem of diffusion defects, such as pulmonary edema or interstitial edema or alveolar proteinosis. Pulmonary edema means there is fluid in the alveoli. Interstitial edema means there is fluid in the alveolar wall. And proteinosis mean there is a chemical substance that can neutralize the surfactant. And that means it will affect the oxygen and CO2 exchange. In addition, it will cause atelectasis due to loss of surfactant and causing low tension. So therefore, you need to restore your functional residual capacity by giving either CPAP or you're giving Peep if you are intubated. And please remember to avoid CPAPophobia or Peepophobia. You can have ventilation perfusion mismatch, and you can know that the respiratory system are divided into 3 zones based on ventilation perfusion. You have the ventilation zone, which is the most anterior part. So if you are lying on the back, it will be the anterior part in the front part. And then you have the match zone. We can have the match zone where the ventilation equal perfusion, and we have the perfusion zone, which is the most dependent part of the body. So if you're lying on the back, it will be the posterior part. The ventilation perfusion can be affected by pneumonia, atelectasis, adult respiratory distress, asthma, bronchiolitis, or foreign body. So your function is to restore the perfusion. So perfusion means if you have, I don't know if you see my camera. Do you guys see my camera?
Yes.
You guys see me? Yeah. So look, this is the perfusion of the vascular system, and this is the alveolar system. So if you have a smaller alveolar system, there is some part of the vascular system will be not in contact with the alveolar system. Therefore, the blood will come from the venous to the artery, causing intra-arterial shunt. The second part, the alveolar bed will be less, so you'll have less exchange. If your vascular part is slow, you will have no intra-arterial shunt, but you will have more ventilated area, and you will have sign of hyperventilation. And hyperventilation, you can discover it by X-ray or lung, or by your, if you're intubated and you're on ventilator, by your graphics. Is that clear? You always need to restore your
Yes,
Doctora,
it's clear.
Doctora Majda. Can you mute yourself, please? Doctora Majda, can you please mute yourself? Ya Allah. Okay. And then we have the shunt, right to left shunt. Right to left shunt mean cyanosis. It can be through congenital heart disease, and it can be such as aortic stenosis, pulmonary stenosis with VSD or TOF, or coarctation with aorta with shunt, or Eisenmenger syndrome, and other congenital heart disease. You can have vascular shunt, or you can have simply because of ventilation perfusion mismatch. So you need to minimize or correct the lesion. Okay. I think I should stop here and receive questions. I think that will be too much. Huh? We can finish next session. So I'm going to stop here and take questions better than, and then we will continue, because remember, we have 250 slides. So you need 3 more sessions to finish this, how to treat a sick child. And if you come today and you didn't attend the previous one, please go and listen to it on YouTube, and then listen to this before you come to the next session. Okay. No, you cannot get the presentation. I can send you, I can give the PDF format of the presentation, not the presentation itself. I cannot give you a presentation, but also you can listen to the presentation on the YouTube. Okay, so questions? General question, this session, previous session, any question, pediatric, neonatology, feel free.
Sorry, doctor.
Yes, go ahead.
Doctor, please, I received one baby infant around 2-3 months old baby one day. The baby completely normal, but the color of the skin is mottled. So the mother is asking why this color of the skin of my baby. Really, when
all the
I
body or one side of the body?
usually the limbs, the lower limbs,
But both sides, not one side.
both sides.
Yeah. So as we said, the mottling is either nothing because it's a vasomotor instability, or it's a grave sign if associated with other signs of shock. The vasomotor instability can be internal in your body, so you have exaggerated autonomic system response, or because of the environment. So being cold, being hot, or your body. If it's asymmetrical, then it's mostly relay day syndrome. Some of the babies that they have relay day syndrome.
Relay? What, please, what's the syndrome?
Relay day syndrome.
What's it, please?
Relay is a vasomotor instability, but it's one side, usually one side. Or they call it familial dysautonomia. I think the other name is familial dysautonomia. That causes some vasomotor instability, but usually it's one side, not bilateral. If bilateral, mostly either inherited vasomotor instability, or it's related to the environment.
Yani, it can be with warm limbs because the limbs were warm, not cold. Yani, it can be.
Yeah, it can be both. It can be cold, it can be warm. It's just unstable. It's just unstable. So, for example, when it's hot, you sweat, right?
Yeah.
So if somebody feels cold, then he has instability. Because remember, in the body, we have a set temperature. So, for example, the temperature is between 36.5 to 37.5 degrees Celsius. So if your temperature is 36 and my temperature is 37, which is both normal, then you need to work very hard to keep yourself hot. So you won't tolerate the cold. I will tolerate cold better because I need to work less hard to keep my body warm.
Yeah.
Okay, so this set sometimes being confused. So one time it's 36, some people. One time it's 36, one time 36.5, other time 37. So they got instability. Okay, it's called familial dysautonomia or relay day syndrome. Just read about it.
Okay, I will read, sure. But doctor, at that situation, how can I deal with the mother and with the baby? Yani, can I leave the baby like that and reassure the mother, that's all?
Yeah, reassure the mother, send the baby home. Tell her to enjoy her life.
Okay, okay. This is what I do, but I'm not sure about what I do. Yani, is it correct or not?
When you are sure, you know, you will be more confident in correcting her. But the most important is that you're sure there is no other signs of vasomotor compromisation. Like hypotension, like bradycardia, like tachycardia, like cold extremities, capillary delay capillary refill, the things that we talked about.
Yes, yes, yes. Okay, thank you very much, doctor.
Most welcome. Any question? I don't mean that I can answer any question, but I will try my best. You need the PDF too. Can you please explain more about Peep with RDS? Yes, Dr. Salma, ask me. Yes, go ahead, Dr. Salma. Okay, so somebody is asking me, Ali Saleh, to explain about Peep with RDS. So you have to use something called dynamic PEEP. So now you need to know how to ventilate dynamic PEEP, which is the best PEEP. The PEEP that you achieve the best match between ventilation and perfusion, but you don't cause intrapulmonary shunt because of low PEEP, and you don't cause hyperventilation because of high PEEP. Most of the PEEP that it's somewhere between 5 to 9, but sometimes you need to go up to 14 or 13. Very unlikely that you can use PEEP less than 5. You probably, if you need PEEP less than 5, you don't need to ventilate. So how to select dynamic PEEP depend on many situations, on your expansion, on your oxygenation, on your mode of ventilation, on your, you have 3 types of PEEP, your applied PEEP, your internal PEEP, and if there is auto PEEP. You also need to look for chest X-ray. You know how to read X-ray for run. You can use lung ultrasound. You can also use your pulmonary graphics, loops and graphics on the monitor to assess the best PEEP. And when we say best PEEP, that you need to be in the safe zone, not under inflated, the red danger zone, and not peaking or overinflated, the dangerous hyperinflated zone. So you need to be somewhere between the opening pressure and the closing pressure, if you know what is opening pressure and closing pressure. And your opening pressure should be never double the PEEP. So if it's more double the PEEP, then probably your PEEP is low or your PIP is high. So your opening pressure should not be more than double the PEEP. So if your PEEP is 6, your opening pressure should be somewhere around 12. So that's how you select the best PEEP. But I know most people, they have PEEPophobia, thinking that PEEP causes pneumothorax, and actually PEEP is a treatment of pneumothorax. Any question?
Please, doctor.
Yes, go ahead.
We want more lectures about mechanical ventilations and long graphs on the ventilator.
I have a good presentation on my YouTube about graphics and loops. I do sessions on complete course of ventilation. So if you're willing to register, you're welcome. It's expensive if you need a certificate, and there are 2 types of certificate. If you don't need a certificate, then it's not that expensive. It's composed of 14 sessions. Each session is 1 hour. Then you need to get a PDF materials, then you get the session, then you get record, and then you have to repeat, then you get questions, and you get case scenarios. So we can take you step by step to be able to ventilate. So there are 14 sessions, you can register with it. I think we will start next week, not next week, next month. We'll start a new group.
How can I register in this course?
You just go to my website and register. My website is written all the page. Look at, let me share the. My website is written in all these slides that I gave. Here. You see all the slides have my website. You see it? Do you see it?
Yes, I see. Thank you, doctor.
Thank you. Yeah, please, anybody interested can register. You're most welcome.
Doctor.
More questions? No questions?
Doctor,
everybody's satisfied?
Doctor,
Should I
please.
finish? Yeah, go ahead.
Please, my name is Dr. Lawal. I'm from Nigeria. I'm listening. I'm listening of your presentation from Nigeria. I don't know, is there any subscription fee for register for this course?
Yes, there is subscription fees for this course, but the price depends whether you need a certificate from the American Association or from Arab Academy, or you don't need certificate. So if you don't need certificate, it's a cheap one. But if you need, it become more expensive. You need and the certificate, because and if you need CME or not, because CME also costs money.
Okay, Prof.
So you just go to website and register, and then look at the website and see the price and communicate with me about what exactly you wrote, and then I can modify the price depending on your needs.
Okay, Prof. But how do I contact you, Prof?
It's just my website.
Okay,
just
so
go to my website.
I can use the website to communicate to you.
Yeah, and you can find my name everywhere, and I will type my phone number. You can communicate with WhatsApp.
Okay, sir. Because I've been following your. So I've been following your.
Here's to everybody.
Okay, sir.
My
Can
phone
we have
number.
your contact, sir? Yes, your
You can text me on WhatsApp.
Okay, sir.
So you can on WhatsApp and on Facebook, my name, on Gmail, on Instagram, on Telegram, I don't know, on Viber, on Twitter, on I don't know, I'm everywhere. You just Google my name, you'll find me.
Okay, sir. Okay, and the phone number is there.
Sorry?
I mean, and the phone number is also there if you Google your name.
Yeah.
Okay, I will do that right away.
Great. Any more questions? No questions? Should I finish?
Yes, assalamu alaikum.
Alaikum assalam.
Can I ask about for extubation? Is it better to extubate the baby after shifting to SIMV or BSV, or we can extubate directly from assist control mode? And which is better?
So you can extubate the baby right away from any mode, including high frequency.
Okay.
So that's the principle. You can. The most important is you need to know the baby will do it or not. So more you know about this, the less the failure of extubation and the need for reintubation. So you need to challenge the baby. How you challenge the baby? By decreasing the, decreasing the trigger. So the more, the bigger the trigger, the bigger the volume, then the more challenge for the patient. So if the patient achieves 3 mil, for example, and your trigger 1 million, then 30% of the patient has to achieve 30. So look at the trigger. What is your trigger? That's one. Second, if the baby can do spontaneous breathing. So if you switch to a mode that can give only support the mandatory breath, and then you decrease the mandatory breath or the set rate, and the baby still can breathe, then that's great. Also use minimum setting, minimum PIP, minimum Peep, and minimum inspiratory time. So if you give the baby and the gas is still and you need room air, you probably will success. But also there are other signs of the failure or success. These signs are gestational age. So I cannot ask, for example, a lightweight champion to fight a heavyweight champion, right? So if you're 24 weeks, I don't expect you to do like a term baby. So gestational age, the disease, the postnatal age, if any disease process, surgery, the size of the tube, the number of the leak around the tube, the CO2, the pH, the oxygen, all this can help you to decide whether you will be failed to. However, it's very important to remember to extubate early. Even if you fail, then that should be okay. Sometimes you fail, you have to reintubate. So usually the first extubation failure rate is around 40%. The second is around 20%. The third is around 5%. So sometimes you have 6 failure. But you also need to make sure that, to give the baby the best chance to succeed with extubation, such as milk, not feeding the baby for 1 hour or 2 hours before, make sure that there is no edema, baby is triggering, the CO2 is high, because remember, if the CO2 low, the baby will not breathe. So maybe you will blame the baby is not able, but you are washing CO2. So to make the baby successful in the CO2 need to be 40 or 50, because that will stimulate the baby to breathe.
Yeah. Okay, doctor. Thank you, doctor.
Thank you very much.
Doctor, most common cause fail of the resuscitation in preterm baby.
Most common cause of failed resuscitation in a term baby is the neonatologist.
Okay.
And the reason is because they concentrate on the breathing.
Okay.
And they leave other things, such as delay cord clamping, antenatal steroid, controlling or rising the room temperature, controlling the body temperature, starting CPAP early, giving surfactant, giving caffeine, starting the dextrose. So most people, they resuscitate, but they leave the baby with low sugar. or they leave the baby with low temperature. So I rarely fail resuscitation, almost. And, you know, sometimes I just watch and my team do it because, you know, they know how I do things and they do it. So failure is very, very rarely, unless I have, for example, lung hypoplasia, or I have severe malformation. But even 22 weeks, if I want to resuscitate, I will resuscitate. And I tell you that 40% of 24 weeks will not need intubation. And about 50% to 60% of 25 weeks, they survive without intubation. So you need to clear, Dr. Asama, your mind. You need to clear. Yeah, preterm baby, yeah.
Okay.
24 weeks. You need to clear your mind that you have to intubate. So you need to think of the resuscitation as a holistic. Very important to remember that. You need to work to do everything to avoid intubation and give time for the baby. Most of babies, they can. Okay, Dr. Hala.
شكرا. Thank you, Dr. Hala. Doctor, in neonatal resuscitation, if the baby less than 500 grams, resuscitate or not? And the 23 weeks.
It depends on the country, on the state. What is the state regulation? But in our guidelines, if the baby less than 500 and or less than 23 weeks is not for resuscitation. But if he or she more than 23 weeks, that's mean 23 plus 0, or the weight is more than 500 grams, is for resuscitation. So these are our guidelines, but does not mean apply for everybody.
Okay, but if the baby is 25 weeks and the IUGR and the weight is 400 grams,
for resuscitation, it's not either. It's not must to be both. So if you are 22 weeks plus 1 and your weight is more than 500, it's for resuscitation. The reason because the only accurate of assessment, because assessment of gestation have loss of error. So the best is that last menstrual period, and the best is when you have IVF pregnancy. But if you do ultrasound at 13 weeks, then the accuracy is plus minus 5 days. If you do it at 22 weeks, it's a plus minus 1 week to 2 weeks. If you do it after 30 weeks, it's plus minus 3 weeks. So when they told you 22, it might be 23 or 24. So that's why you have to depend on the weight too. So if the weight more than 500 grams and or the gestation is more than 22 plus 6 in our guideline is for resuscitation. But it might change. So if you don't have good resources and the baby will die anyhow, so you need to concentrate better on older gestation better. So it depends on I think in Japan is in Japan
is less, and 22 resuscitate, and so in Japan 20. In Japan there is a
20,
paper.
20 is not possible. 22 maybe. 20 is not possible because the eye is closed. No eyes.
22, I think. I think 22 and 400 grams in Japan resuscitate. There is paper about this. And
not very correct. Not very correct. They are not doing very well. In Japan, they are not doing very well. Don't believe. I went there and I know. They're not doing very well as they claim to. Don't believe everything they say.
But in NRB guideline, 23 and 500 grams. And
NRB is not a program for organization, but it's not a guideline.
Okay. So I wanted to ask you about. Okay,
go ahead.
Shut the hive.
No, I thought I go to another person. Go ahead, ask me.
Okay. I want to ask you about infant came with foreign body injection. We see a lot because I work in ER. See a lot foreign body injection in here. Foreign body coin. And
ingestion or inhalation?
Ingestion. Okay. Coin.
Okay.
And the patient came with salivation and no stridor, partial obstruction of the airway, and saturation was okay.
So and aspiration, not ingestion.
Aspiration.
Okay, aspiration of a foreign body.
And when I did chest X-ray, the coin is present above the carina, and saturation
in
was
the
okay.
Airway.
In the airway. And I fear to open the mouth or to do anything.
You don't open the mouth. You need to do rigid bronchoscopy.
But in my hospital, you don't have ENT physician, so must transfer this patient. and
have to.
and
You have to do
transfer,
your
and
primary
the
assessment
parent
secondary.
pushed me to open the mouth, and I told them no, nothing, to keep in triangle breathing position only, and keep the saturation was okay, 98, and then transfer the patient.
You can do the maneuvers. You can do the maneuvers, Sue, that you are allowed to. You cannot open the mouth and play, but you can do the maneuver. You can do
Like for
the
slab, for chest and abdomen.
So you know, chest thrust or the abdomen thrust. That's all you're allowed to do, and then you have to transfer the patient. You cannot put something
I
unless you
fear
have
to do
rigid
anything because I fear I fear foreign body to move inside or to go to the trachea to
that's why you should
airway.
not play. You have to do the maneuver. You should not play.
But I can I did the maneuver or no? Can I did?
The maneuver you have to do it. It's in the guidelines.
I have to do. Oh,
yeah.
Okay. Thank you.
Dr. Scovia.
Hello.
Hey.
Sorry, I'm not a doctor. I'm a midwife.
Yeah, go ahead. It's okay.
Yes. I have a question. Like after you have resuscitated the neonate, let's say with an APGAR score of about 6 or 7, how long should you keep this baby nil per horse before you can start? Because I faced a scenario whereby we resuscitated this baby who picked up very well, and afterwards, after like 4 hours after the resuscitation, the baby's condition again worsened. But like the resuscitation took about 5 minutes. We did it, baby picked up well, and within an hour, we were able to get the baby to breastfeed and was doing well. We gave the baby to the mother, but within 4 hours, the mother came back with the baby already cyanosed, and we started to resuscitate again. And unfortunately, we lost this baby. So I was wondering, how long should you keep the baby nil per horse after you have done some resuscitation to a neonate to be sure that all is well?
Okay, so first you cannot, now if you attended yesterday presentation about resuscitating a newborn, you have to decide whether to keep the baby monitoring care or well baby care or intensive care. So if you did resuscitation for 5 minutes, this baby need intensive care, whether he's okay or not. So if you respond to the first step of resuscitation, you go for well baby care. If you respond to the second step of resuscitation, you go for monitoring care. But if you're not responding for the second step, which means 1 minute after resuscitation, you need intensive care for at least 48 hours before sending the patient home. So I think the mistake here is the post-resuscitation care.
Okay.
Yeah, I think that's the problem. So you have to go with the guidelines and do the post-resuscitation care. And intensive care means you have to admit the patient to an ICU, probably keep MPO for a while, start IV fluid, make sure the GI is open, make sure your heart is okay. You can do a blood gas, check your sugar, see if you have a congenital heart disease, make sure you don't have infection. So these are all called intensive care. So if you respond to first step of resuscitation, it's a well baby care. If you respond to second step of resuscitation, it's a monitoring care. And if you're not responding to the second step, then it's an intensive care. When the second step mean more than 1 minute of resuscitation.
Okay. But now, like in situations like where I am working, these are very low resource settings where we do not have, maybe we're not even able to do sometimes the ultrasound scan. You cannot do x-rays to check for those abnormalities. Even the intensive care, you do not have like the facility to be able to do intensive care. I mean, a remote setting in a conflict zone where I'm working with midwives, basically, I don't have a pediatrician, I don't have a neonatologist. So what is the basic mode of care that I can do with the midwives to be able to help
once
with neonates?
in that situation and you did your resuscitation and you lost in resuscitation more than 1 minute, first you need to check the temperature.
Okay.
Second, you need to check the sugar. Can you check the sugar?
Yes, we do have the RBS machines, the glucometers.
And can you check the saturation?
Yes, we have the pulse oximeters.
Yeah, so do you know how to do critical congenital heart disease screening by saturation?
Nope.
Okay, so what you can do is communicate with me on WhatsApp. I will provide you with a guideline on how to care a baby post-resuscitation without a pediatrician, without a doctor. Okay, and what exactly you should do. And I can give you a presentation, you and your colleagues, on how to do that. and I can
Thank you
provide
very
you with guidelines. So did you get my phone number?
No, I didn't get it.
Yeah, can you go to the chat? Do you see the chat? Do you see the chat? Mom, can you see the chat? Yes or no? Scovia, do you see the chat?
Hello,
Scovia?
I mean,
She
yes,
is in
please.
mute.
Sorry,
Yeah,
I muted by mistake. I'm in the chat section. I can see the website, but I can't see the phone number.
Phone
I don't know
number.
if I lost it.
You don't see the phone number to everybody?
Okay, maybe I have to go through the chats.
I will look at your name and send you your name by message.
All right. Thank you very much. That would be very
You're
helpful.
most welcome. You're most welcome. Take care.
All right.
So now I will write then and tell me if you see it or not.
Okay.
Do you see it now?
Yes. Yes.
Okay.
Thank you.
Okay, most welcome. Okay, so I saw other bodies, Doctora Mirieta, you're asking a question you want? You're raising your hand? Is that by mistake? Okay,
That
that's
was
fine.
by mistake.
Okay,
Excuse
that's okay.
me.
That's okay. Any more questions or I should close?
Yes, Assalamu alaikum.
Alaikum assalam.
Dr. Yahya,
Yes,
can
sir.
I ask about PDA for
Yeah, ask about PDA, please
medical
do.
closure?
Okay.
If we don't have endomethacin in our country,
Which PDA you
which
are
is
talking
better,
about? PDA of
ibuprofen or
prematurity or
paracetamol? And
congenital heart
what
disease?
about the dose? Prematurity.
PDA of prematurity. Okay.
Prematurity. Yeah.
Okay.
Yeah. Which is better, ibuprofen or paracetamol? And what's the dose and what's the
Each
duration
one has
of
a
treatment?
success rate and has a side effect. That the side effect of paracetamol is way less. So usually I start with paracetamol. You can I can send you the doses if you communicate with me. I send you, but usually it's a 10 milligram per kg per dose. You can give twice, you can give 3, you can give 4 times a day, depending on the gestation and the maximum dose. What I do is I give it for 5 days and then I check the PDA. If the PDA become restricted or closed, then I stop. And if not, I continue for 7 days. And if for 7 days not responding and the baby otherwise is growing, there is no ventilation, or even there is ventilation, there is no increased setting, gas is okay, I might wait. I'm gaining weight, because the more you gain weight, the better chance of closure. And then you go to other options. Sometimes you need to close it by endomethacin, but you have to check the platelet, the sodium, the creatinine. And if it's okay, you can give the dose and check. And if it's closed, then great. Sometimes it's not, you might need a ligation. But most of the time, 50% of patients by watchful observation is okay. And most of the babies respond to paracetamol. I rarely might have to add other medication, and sometimes I have. And you have to, before you decide, is it hemodynamically significant or not? And these are many factors, such as the gestation, the postnatal age, the weight of the baby, the size of the PDA, the direction of the shunt, is there any consequences, such as measurement diastolic flow in the aorta or in the left pulmonary artery, also the LA ratio. There are many things that we use to, the cardiac output, the difference between right and left. There are many things that we do to decide, is it hemodynamically significant or not, and then decide to treat. But the best treatment is either observation, if you don't have symptoms, or you don't have escalation of symptom, or paracetamol, and then you decide. So usually I give it for 5 days, do an echo, and if it's closed, I stop, and if not, I continue for another 2 days.
Okay, thank you. Can I ask another question?
Go ahead, please.
Regarding to the rebound jaundice, is discontinued phototherapy, this can cause rebound jaundice, or if the risk factor is still there? Some of my friends said you discontinue the phototherapy early, you need to keep it for more 1 day to avoid rebound jaundice. Is it correct or not?
No, no, because phototherapy also associated with adulthood cancer. So you don't need to continue phototherapy if it's unnecessary. If it's 8 to 12 hours and there is on photo and there is the, you know, the below photo line, then you need to stop. I don't think it's necessary. For the rebound, I think something is wrong with the management, either improper assessment of the level of the jaundice or the risk of the baby, if there is setup or not. But if you have a continuous hemolysis, you will rebound anyhow. But anyhow, the baby will grow, the blood-brain barrier will mature, you need less photo. So I would not suggest to give prophylactic phototherapy.
Okay, thank you, doctor.
Thank you. Any more questions?
Baby with the preterm, doctor. Baby with preterm, baby with the bilateral cleft lip and
cleft lip only, not palate.
Bilateral cleft lip and palate.
Okay.
You can resuscitate and not fail the intubate. You can get that.
So bilateral cleft lip and palate. First, you don't need to resuscitate bilateral cleft lip unless the baby needs resuscitation. That's one. Second, you don't need to intubate unless the baby needs intubation. So what's the question?
Baby with low heart rate, tachycardia.
So the baby needs resuscitation. You have to resuscitate.
Need. Yes.
Yeah, you have to resuscitate, of course. But what is the question? How to resuscitate or to resuscitate or not?
Yes, you can
so if you can provide PPV by mask and bag, then you can. Mostly you will not be able to provide CPAP. So if you cannot provide by nasal cannula, and you'll have lots of secretion, so you have to give the baby in a correct position. And if you cannot, then you need to intubate right away. Mostly you are not able to give CPAP. That is the only difference. Mostly you can do PPV by mask and bag. And you can give also oxygen, blended oxygen. You can use high nasal flow, but sometimes you fail because the mouth is open. And sometimes you need to go directly to the intubation. That is the difference, the only difference with the cleft lip.
Between, okay. Thanks.
Thank you.
Doctor.
No more questions?
Doctor?
Yes, sir, tell me.
What's the optimum pressure for late preterm baby, and why late preterm baby more prone to develop pneumothorax rather than extreme baby?
What is the which pressure? PEEP you mean or PIP?
Both.
Okay. So why the late preterm develop pneumothorax? You're correct because of the pulmonary mechanics. Because preterm baby is more with RDS, while higher gestational age baby more with TTN. And therefore, when we use dynamic PEEP, so let's say the range of PEEP that you will use between 5 and 9, in term baby, use lower and go up. In a preterm baby, you start with higher and go down. The reason, because mostly the premature baby is you have atelectasis and easy to achieve functional residual capacity. In a bigger baby, it's mostly fluid, so the lung is stiff. While in a premature baby, the lung is not stiff, you're just not having the surfactant. So it's easy to inflate. And because the lung is stiff, when you put more pressure, you break, you cause shear force and you can cause pneumothorax. So therefore, in the first 1 or 2 days in a big baby is more than 30, you have to be careful of your PEEP because of stiffness of the lung. So you can look, if you are intubated, you can look to your pulmonary mechanics. And if you are not intubated, just be careful to start with lower and go a little bit up. So I rarely go in a term baby with a PEEP or CPAP of 7 and 8 in the first 48 hours. And so in a preterm babies, I can go to 9 and I have no problem. But if you want to go, then until the fluid is clear, then after 48 hours, you can go with higher PEEP. But that's the reason, because the lung is stiff due to presence of fluid, interstitial and pulmonary fluid.
Yes, but what about PIP, peak inspiratory pressure?
PIP, the closing point should be not more than the double the PEEP. So that's how I select the PIP. If you look at the graph, the closing point should not be double. So if you ventilated, look at your pressure volume loop and look at your opening pressure. So the opening pressure and the closing pressure. So the ventilation should be between opening and closing pressure. So from the start of PIP to the closing pressure should not be more than double the PEEP. So these are rough starting point.
There is range or not for PIP?
There is range. I can tell you range. You know, if you are less than 25 weeks, early 20, and if you are 25 to 28, then probably mid 20, and if you are more than 30 weeks, you're 30 or between 27 and 30, you are late late 20s and maybe early 30s. But that is not enough. You need to look at your graphs and loops and to decide. Because if you give high PIP, or you can use volume targeted. If you have VG, you just add VG 3.5 or 4 or 4.5, maximum 5, somewhere between 3.5 to 5 mil per kg. And the VG will determine your maximum PIP. So if you have VG, just add VG. But when you have VG, you should have not leak. That's the problem. So if you have leak, you probably won't able to use VG. But if you can use VG, it'll help you a lot. If you don't, then start at a point and then look at your graphs, your loop, your blood gas, your chest rise, your inspiratory time, your rising time, and look at your graphs, your tidal volume, your minute ventilation, your C dynamic and C20 and C20 over C dynamic. These are all numbers can help you to determine the appropriate PIP.
This is same for an IV.
And what do you mean? A non-invasive ventilation?
Yes.
Non-invasive ventilation, I don't use it frequently. I don't believe in it. But I think it depends on the CO2 level. So let's say you want to give EPAB of 7. I will give IPAB of 14, double that, and I look for CO2. If the CO2 is okay, I will drop it a little bit.
Okay.
Remember, yeah. So, and the rate, I usually, if I want to start an IV, I go with rate of 30, for example, and then look at my CO2 and I wean if I need.
Thank you, doctor. Thank you.
Any more questions? I think we should stop here. Took 1.5 hours, more than 1.5 hours. And we'll see you next time for the third session of how to manage acutely ill child. Thank you very much for attending.
Thank
and you
doctor.
Can look to the video on YouTube. Thank you very much.
Thank you
Have a
very
good
much.
day.
Thank you.
Doctor.
Anyone
Thank you.
want
Thank you
the
very much.
PDF can communicate with me. Bye bye.